at risk for shock. They're at risk for hemorrhaging. And you can bet their bottom dollar that that CRNA and those nurses are going to be watching that blood pressure. They also are at risk for having a stroke and PEs. You know what a PE is? So there are a lot, we've got to watch these patients who have that history of any type of cardiovascular problem. Pulmonary problem. I think we talked about respiratory a lot. I think we pretty much got that covered, right? Of what's going on. My patients that have problems with respiratory are very, very difficult sometimes to get off the ventilator. So patients who have a history of smoking, have a history of COPD, have a history of emphysema or asthma, they have to really, really watch them to make sure that they're having adequate breathing and they're perfusing correctly, but they also have to watch them as far as the medications, because the majority of the medications that we give to put somebody to sleep, the side effect is respiratory depression. Okay, so we really got to watch and be on these people, and they are very, very difficult to extubate. So it may take them a lot longer, and we understand what's going on. And then that, I don't want you to sit here and think, okay, just this is a COPD patient. This is any patient who has respiratory problems, i.e. if they smoke or have had asthma, they're difficult to watch or difficult to get off that ventilator. So we know that we've got to watch them. And I've talked to you about the cilia. I know you've heard that. And I just put this up here just to remind you. But I'm not so sure that you've heard the term atelectasis. Has anybody heard that term?
Collapse lung.
Have you heard that term before? And what that means is that the alveoli, in no relationship to the patient having COPD, having any respiratory problems to begin with, it is you're just collapsing, or any respiratory patient will collapse, or any patient period will collapse those alveoli as a result of the medications that we're giving them from being intubated and all those extra things. It's very, very common that you will see this. So not everybody that has a history of smoking is going to be the ones that have these. Anybody can have atelectasis post-operatively due to the fact that that is having problems with the anesthesia. So as a nurse, we know that this can happen. So we are always having them do what after they wake up?
Turn, cough, and debrief.
Turn, cough, and debrief. Absolutely. I can't let them collapse their alveoli. All right, diabetes. Talked about that. Y'all just got finished with diabetes. You know that these blood sugars can get out of whack because my patient is under stress. And stress makes... I just figured I'd just go ahead and lecture the whole time and we can do it next week. That'll be better. I just knew that you were going to be running crazy. So, okay. All right. That works. All right. So, we're not just looking at hypo, we're looking at hyper as well. That stress is going up. So we've got to really watch it. And then it's sort of like a snowball, isn't it? And I think y'all learned that when you talked about diabetes over the last couple. It's more like a snowball. And it just keeps happening. It's going up and down. They don't heal their wounds good. They get infection. You know, all these sort of just continues. So we've got to make sure that we're going to maintain that blood sugar. And the majority of patients that are diabetic, pre and post-op, we have to really, really expect them to be on a sliding scale, wouldn't you think? So watch their sliding scale. Renal and liver dysfunction, we know about. I know that I've talked about meds and how they do. But with our renal problems and our liver problems, that's going to put my patient at risk for bleeding as well. So we've got to watch them for bleeding as well. Medications. And Samantha was just telling me that one of the things that she's noticed in her practice is that patients don't want to tell us everything that they've taken. I.e., if they come in and they just smoked a joint, or if they snorted some cocaine, or if they injected heroin. They just don't want to tell us. First of all, they're afraid that we're going to call the cops, or they're going to get in trouble, whatever. But I have to develop a relationship to that patient and explain to them how important it is. I'm not judging you. All I'm doing is I am making sure that you tell me everything that you have had, because we're getting ready to give you a bunch of medications. And it's going to react positively or negatively with whatever you've taken. And either you can die from having a mixture of heroin and anesthesia, or you tell me what you did so I won't take that chance to even putting you under anesthesia if you just shot up some heroin. Okay, so it's vital, guys. We've got to develop a relationship with them so they know what did they take, so I can see if it's going to react. One of the other things, I think I got it on here, so I'm going to get ahead of myself. All right, so not going straight, I went straight to the drugs. But let's go back to the medications that patients are on very, very frequently when they go into surgery prior to. Anticoagulants. We see lots and lots of patients on anticoagulants prior to coming to surgery. This is one medication that I have to have them stop at least 5 days prior to going to surgery. So you can see where the pre-op education starts as soon as we decide when the surgery is. So I've got to make sure that that patient knows if your surgery is on the 17th, by the 12th, you stop that anticoagulant. Okay? I've got to make sure that they understand, yes, this is the day that I don't take this medication anymore, because you know what anticoagulants do. You know when I put patients in surgery, they're already at risk for bleeding. Do I want them to be thin? No, to increase their size. I've got to make sure any NSAIDs, aspirins and NSAIDs, patients have got to be educated. You can't just go and say, are you taking any NSAIDs? They don't know what that is. You got to tell them. They may say, and you say, are you taking any anticoagulants? They don't know. Are you taking anything to thin your blood? Okay, let's talk about this. And you've got to get them to tell you everything that they're taking. So many times they don't think that an aspirin is a medication. So many times they don't think fish oil is a medication. Well, do you know fish oil makes you bleed out too? So I gotta talk. Tell me what vitamins you're on. Are you taking that apple vinegar, whatever that everybody's taking right now, including me? Okay, what are you taking? Let me know.
What do they do in an emergency situation? Just hoping for the best?
Hoping for the best. Because you got to realize that when I say emergency, my patient's going to die if I don't do something.
Risk or benefit.
You know?
Well, I guess what I was getting at, like, if they're in an emergency situation, you know that they take an anticoagulant every day. Is there something that you can give them in the OR, before the OR, real quick?
The biggest thing I'm going to have is blood. Yeah. So when they start bleeding, then I got it to go. Yeah. And an emergency situation is very, very hard too, because you got to type and CrossMatch, and you got to make sure that you give them so it's yeah, and it's hard. But I got to say, if my patient's dying, if I don't do this right now, my patient's gonna die. So this is more of a preventative. Let's don't get into that situation in an emergency. Let's take it slow. All right, Coumadin, we've already talked about. I mean, you know what Coumadin is. sometimes they will have you taper Coumadin instead of, because you're not supposed to just stop Coumadin just like that. My aspirin I can, NSAIDs I can, but Coumadin, they're going to tell you, and it may take 2 weeks before they go to surgery to figure out how to taper it down before they go in there. So that is not my call. That is the surgeon or the medical doctor to say, okay, I'm going to have a total knee replacement on this day. I need to know how to take my Coumadin prior to going to surgery. So as a pre-op nurse, you need to, when you talk to them about their medication, if they say to you, I took my Coumadin yesterday, what do you think is going to happen? You're not going to surgery. And so do you see where education is so important? I'm not just going to say, okay, you need to taper your Coumadin off, but I'm going to tell you the reason why you are tapering that Coumadin off. And I think so many of us nurses just tell our patients, do this, and don't give them the reason. Because I don't know about you, but I know patients get very, very anxious about surgery and leading up to, wouldn't you hate to have prepared yourself all the way up, and then the day of, you go in there and say, sorry, you can't have surgery, because you didn't do that. And that falls back on the pre-op nurse. Why didn't she educate? That surgeon's nurse should be educating that patient and let them know that we can do everything we can to not cause it to be where we have to cancel it. And one of the biggest things, speaking of an emergency again, is one of the things they'll do is they'll go ahead and do that PT, PPT, and INR. And one of the things we're hoping for is that those are within normal limits. Because if I've got somebody that's, their blood's too thin, then I'm going to have to get 15 units of blood up there as opposed to 5. Okay, because they're going to continue to bleed, and the more they bleed out, the more we push in.
One of the things that we do in our office with dental work is we'll ask them, we don't say, did you stop taking it 5 days ago? We'll ask them, what day did you stop taking it? Good. Because they'll say, oh yeah, I stopped taking it 5 days ago, and they really just stopped taking it 2 days ago. And you can tell because then they just bleed out.
Right. And they don't understand the importance of it. And that's where I get very aggravated is I'm the kind of person, I don't even know the reason why. Don't tell me just to stop it on this day, tell me why. And if it's going to help me, and we put the ball in their court and say, you know what, we really need you to stop this on this day, because if you continue it, then there's a risk of you having this problem. All right, diuretics. We know they're on diuretics, and a lot of times people are on diuretics for blood pressure. Okay, so we've got to remember that if they're taking diuretics, I've got to watch that. The potassium and your other electrolytes before they go in there. That's a medication that they don't have to taper off. You know that you would have expected them to take it the day before. So then I know, oh my gosh, they're on Lasix. They take Lasix every day. I better check that potassium level before they go.
So they don't stop.
They
don't stop.
No, that's not one that they have to stop. Just my anticoagulants are the ones that I need to stop prior to or taper off. But the other medications, diuretics, blood pressure medication, the anesthesiologist, they will meet with the anesthesiologist prior to their surgery. And they will have a list of all the medications that they're on. And they will say, don't take this one, this one, this one, and this one. But there may be, like with blood pressure, sometimes they may say, take this with a sip of water as soon as you get up. And that isn't because they're going to be NPO, so take it with a sip of water. And you know how hard it is sometimes. I know when I've gotten patients ready for surgery and they're in the hospital and I go in, I was like, you can only have a sip. And you take them a little tiny sip in there and they're like, they hadn't had anything to drink since 12 o'clock and they're like, give me some more water, give me some more water. But it just needs to be a sip, enough for them to get down, because I don't want them to get in there and get in the OR and get in a situation where their blood pressure goes up. Okay? But that is not our call. Okay, that is the anesthesiologist's call. And I've got to follow what he says. Okay, antihypertensives, we know that we've got to watch that blood pressure. And you will see that in the pre-op situation, they will do vital signs as soon as the patient comes in, and they will do another set of vital signs prior to them going to the OR. Okay, so I've got some readings to go on, so I'll have a baseline that when anesthesiologist or the nurse anesthetist gets them, takes them back, and they can say, well, this is what the blood pressure has been, and then they can see what the medication's doing to it when they put them under anesthesia. We talked about herbs. It is vital that you figure out what all they're taking. Specifically, fish oil is one that makes you bleed. All right, temperature. I don't know, I'm about to lose my voice. Aren't y'all wishing? Now I would lose my voice. Let's see where we're at. I'm not trying to rush, but I don't want to. Okay. All right, temperature variations. Remember, we've already talked about being very, very cold in the OR. So we've got to watch the patient. You also will see that they will monitor that temp. They have a little probe that they put in their nose, and that gives us an accurate reading of their temp. They will monitor that temp regardless, throughout the whole time they're in there. One of the things, when they get out of surgery, you cannot take the patient out of the OR until they have reached an adequate temp.
97.
Is it 97? They have to be at 97 before they can take them to the pre-op, because that means that temperature, we don't think about if we have a low temperature, what's it doing? What does it do when your temp is low? Everything starts doing what?
Tighten up.
Sort of tightening up, just like when you're cold and you just go like this to try to get warm. Your organs are doing the same thing with that temp. I need those organs to be open. I need them to be ready for some oxygenated blood. And if I've got a low temperature, I'm going to start clamping down, and I'm not going to be able to perfuse like I need to. So we have to make sure that that patient is well 97 or above before I take him out of there. The other thing that we want to make sure that when we're talking in the pre-op, I always ask patients, have you ever been asleep before? Have you ever had surgery before? And the other thing is, how did you do with anesthesia? Okay? Because if I know, and we had one, who was it that had one out of control the other? Hannah. What was your patient telling him before he went to surgery, telling all of us?
He felt sorry in advance because last time he came out of anesthesia, he was going crazy and everything. And the CRNA kind of came out of it, and then when he came off, he was just going just crazy.
Mm-hmm. He was fighting and all this kind of stuff, but he warned us. He was trying to tell them, this is how I act when I come out of anesthesia. And nobody was listening. And so, then we got in, and he was fighting and all that kind of good stuff. So why do we ask questions if we don't want to listen? Okay, so we've got to make sure that we know how they react.
I had a resident that she coded one time when they gave her anesthesia, and she went to go get a check line put in, and I don't think they paid attention to that in the chart, because when she came home, she ended up coding, and she said that ever since they brought her back, she didn't feel good, so she wrote a DNR. So she ended up dying.
And then why can't we listen? Why do we ask questions if we're not going to listen? We should have been ready for this little man to maybe had some padding right there, or maybe had something that we could have calmed him down a little bit. Something. Now, I vomit. So I'm telling you right now, if y'all ever in the surgery with me and I'm coming out of anesthesia, I'm going to vomit on you. So get ready, and it's projectile. So just get ready.
She was fighting her
We need to look at that. People get anxious during that. So there's a reason why we ask them those questions, because that's what happens. Another thing you need to look at is allergies. Patients have a lot of, it's more frequently now, they have latex allergies. And when they go into the OR, they will have their own kit. It's just like a little tackle box that you're going fishing with everything that they need in case they have allergic reaction to latex. Another thing I always ask patients, are you allergic to shellfish? Because sometimes shellfish have the same type of allergies as latex. Another thing I found, I read an article a couple years ago, is bananas. I asked people specifically, are you allergic to bananas? Because there's been connection. If you're allergic to bananas, you also have an allergy to latex. You may not have been in contact with latex before, but you know you've had allergies to latex. And so what I would do is say, okay, she's allergic to bananas. I don't have any positive reaction from latex, but let's go ahead and make it latex free, just to prevent that from happening, just in case. All right, so autologous. Have you ever heard that term before? Yeah. Do you know what that means? Autologous means I'm going to use my own blood. So there are patients that are times that we know that it's going to cause a lot, or the patient's going to be at risk for bleeding, i.e. bone surgeries, hip replacement, knees replacement, lots and lots of bleeding that could possibly take place during this surgery. So what happens is patients can donate their own blood. Let's say I'm going to have my surgery in 3 months. I know that I got to have that knee surgery. I've been putting it off, but I can go and donate my own blood. So just in case that I need blood, that I can have it on hand when I go to the OR. So I don't have to have somebody else's. But when you donate, you have to meet certain criteria. I'm sorry.
I just want to know, are Jehovah Witnesses able to do that?
No, Jehovah Witnesses will not take any blood product, their own or anyone. Yeah.
I think they would take their
They will
own.
not take their own.
That has additives.
Yeah, there's nothing, they will not take anything. And I'll speak to that in just a minute.
That would have been an option for them.
There's certain criteria that they have to meet prior to making sure that they donate. They have to be afebrile. They cannot run a fever when they go and donate. Their hemoglobin also has to be greater than 11. So if they're anemic prior to, then they're probably not going to be able to give their own blood to be given at surgery. You cannot donate within 72 hours. And you may be, at that point, if we see that you need it and you don't have a lot on hand, you may have to be accepting of other people's blood at that time. One of the things that, and it's not the pre-op nurse's responsibility to make sure, or to get the blood, but we have to make sure if we see on a chart that the patient, and it'll have a big red sticker on it that says autologous. So when you see that note, or you see that big red sticker, as a pre-op nurse, you have to call the blood bank and make sure that that patient's blood is on site and up in the OR before we can do surgery. I have seen surgeries be canceled because their blood was not there. The patient said, I'm not having surgery because my blood's not here. So it's vital that if you have that big red sticker on there, that you make sure that that blood is there prior to them going to surgery. What is wrong with my voice? All right. Did I go backwards? Okay. Now, when I usually say bloodless surgery, everybody says, "Oh my gosh, how can you have a bloodless surgery?" Well, because of their religious factors or any kind of medical restrictions, patients who are going to surgery before, there's things that we can do to help them decrease their chances of bleeding in the surgery. Does that make sense? It's not that they're going to have a bloodless surgery. They're still at risk for bleeding, but it's things prior to that we can do to assist them from not bleeding so badly. One of them is, let's stop checking their blood over and over and over again. Okay, because if you think about it, what if they took 5 vials, every time they went and took their sample? We can give the patient Procreate or Epigen. Have you ever heard of those 2 medications? They're given a lot for patients who have cancer to stimulate the red blood cells production. So those 2 medications will help build our RBCs. They'll help produce them more and more and more. The one bad thing about those 2 shots is they're $3,000 a piece.
That's why we're not giving them to every.
That's why we're not giving them to every patient. And insurance usually does not pay for that. So it's a very expensive medication.
Wouldn't it be cheaper, even though, we're
Absolutely.
but I feel like it would be cheaper to give them a shot and not have any complications, because if they have complications, then you're going to have to pay more for it.
And see, that's why insurance doesn't think like us. They don't think like us. Let's do stuff to prevent this from happening. But they can't, they're not nurses, they're not doctors. They don't think like that. They're saying, "Oh my gosh, this is $3,000. I don't want to pay this $3,000. But yet, you're going to have to pay when that patient hemorrhages and be in the hospital for a couple more days.
It's $3,000 a day.
Oh yeah, they do. That's why insurance drives me crazy. Let us dictate what's going on and let us figure out what's going to be best for this patient.
I work in the blood bank, and I had there was a patient that had sickle cell anemia, and she had so many transfusions and gained so many antibodies that nobody matched her blood.
Right.
She would either get that stuff or she would get the closest compatibility.
Right. And that's sad.
Yeah, she ended up dying because.
Yeah. It's sad. But these patients, then there's other things that we can do too, like iron. We can give them a lot of iron, and iron has a lot of side effects. So it makes you constipated, it makes your poop look black, and all this kind of stuff. So it's like there's things that we think, and most of the time we give iron and it's like 324 milligrams. Did y'all ever see an iron that's 324? It's weird. It's a 324 milligram tablet. It's not 325, it's 324. Why? I don't know, but it's 324. But anyway, we can give those several. One's not going to do anything. So if we give more than one, that's really going to constipate them. Yes.
So, people who get that after the surgery, are they going to have to apply this for this? We're going to put them on blood sugar after the surgery.
Most everybody that has surgery is on, after surgery, they'll be on Lovenox or something like that to help thin it. No, I don't think there's anything. Maybe we can just give them extra iron and maybe continue to give them Procreate or Epigen, either one. Now, I've let my students give these 2 drugs before, and I've been a nervous wreck knowing that I was going to draw up those meds and give them. But you may have to at some point. Folic acid will work too. That's over the counter, but that sort of takes a little bit longer to work than our iron. All right, so we talked about discharge planning begins immediately. The other thing that I think you got to remember is when you're planning this discharge, i.e. if a patient has a hip replacement, you got to be able to get that, make sure that that house or his home or wherever he's going is going to be suitable And does he have access to everything they need? And that is included in your discharge instructions. Okay, so that is pretty, we'll talk more and more and more about that. Okay, lab assessment. I don't know why I'm coughing. I'm losing my voice. Ah! Okay, lab baseline. I've got to know what the baseline is. It can be up from 24 to 48, the 28 hours, or 28 days, 24 hours, 28 days. But most patients, or most doctors will not go no 28 days. That's a long time. There's a lot of things that can happen in 28 days. So they usually like to have within 24 to 48 hours, have a good idea. So as a pre-op nurse, one of the first things I do is I go and look at those labs. And I know sometimes we don't want to look at the date, but you gotta look at the date. When were these labs done? And are they within normal limits? And if I've got something that was done 24 hours ago, and it's a little bit low, then I have the ability to call and say, I need another blood drawn. I need to see this CBC again, because I might be the one that catches something that nobody else caught. And I might be able to want to see that hemoglobin was low when they did it 48 hours ago, but I need some reassurance that it's okay now before that patient goes into surgery. So you can call and say, I need to have another lab value done for this. I just wrote these down, and I've said this over again. I'm giving you an idea. Your CBC, you know what's on that. We haven't talked so much about type and cross. Do you know what a type and cross match is? This is something that's not really seen every day. What you have to do is you have to make sure that the patient's blood type, we know what blood type it is. So we know that there's O, is it positive or is it negative? Because if some reason that patient goes in and starts bleeding, I have to know which blood that patient can get and does it match his blood type. Because in an emergency situation, not everybody gives their own blood. So if it's an emergency situation and I've got to give that patient blood, I have to know his type and I have to know that if it's going to match. They will have, you seen the red blood bank bracelets, okay? So when everybody that's type and cross match will get a bracelet with the blood that matches their blood in the blood bank. So that is the way that they tell what works or what's going to work with that patient. The other thing I want to tell you is I would love for you to go with somebody to see how you check out blood for a patient. There are multiple checks that have to be done. Because we can give somebody the wrong blood and them have a reaction and die. So there are lots and lots of checks that have to be done, and we have to make sure that what I give Deborah is going to match her blood type and it's going to work for her. Okay? You know about the electrolytes, BUN, creatinine, ALT, ALST, and I told y'all last semester you got to start learning those values, so I just put y'all another little note up there and said, learn those ranges. I think y'all are doing good with that. We know about albumin and total albumin. Everybody know about albumin? You should be learning that with diabetes too. That's going to tell us about their nutritional status. UA, we always try to do a UA on patients regardless of what type of surgery they're having. But they also have a pregnancy test that needs to be done. I've seen so many people come in and say, I'm not pregnant. I hadn't had sex in a while. First of all, I don't care when you have sex. And if you're a female between these ages and you still have a uterus, I'm doing a pregnancy test on you. Okay? They're doing it on you because I don't want to take a chance of going to surgery and you being pregnant, because that would not be good.
I have experience with this patient. The nurse asked them within the mental period was there. So the nurse looked at the physiologist was there, and any chance they can be pregnant? She said no. I was talking with my teacher, and they should have done.
Absolutely.
And it was not done.
Absolutely.
But that was something that was I mean, they don't usually do it.
Right. And even if you just had your period last week, I'm still doing
And
one.
even if she
We're
was
still doing
44
one.
years old, like, she didn't have a hysterectomy.
44 years, I'm 53, I'm still active. I'm 53, I'm still active. I ain't got a uterus, but I might be rich one day if I get pregnant with no uterus.
But I mean, it was like they would say, no, I stated
Right.
they
gotta do it.
word. And I was like, and then she was going to see the x-rays and everything, and I'm like,
And that's damaging that baby in there. It is there.
So the perfect example when we went in and watched the policy, could that have been a good example as to why they have a pregnancy?
Absolutely. Because she went straight
With them.
into the uterus and they dilated her too, didn't they?
Yeah.
Yeah. Yeah, not good. All right. Everybody should have a chest x-ray prior to going to surgery to see if the patient has a history or has pneumonia. Because if they have pneumonia, they're not going to surgery. Anybody that has infection, so you should have a chest x-ray prior to. Sometimes they'll do a CT, sometimes they'll do an MRI. Like with my shoulder, I had to have an MRI. Before they would have operated on me to see that I had all this damage done in my shoulder, then yes, I had to have an MRI. And that would give me proof that I can go to surgery. All right, nursing diagnoses. One of the biggest things is deficit in knowledge, because we've got to teach patients. And anxiety. Please don't look at anxiety is not important. The other thing is powerlessness. Powerlessness. That patients feel powerless. They really do feel powerless. When we come in there, it's like, take your clothes off. We're going to do this. We're going to do that. So give them some choices on things. We got to say, just like I've said, give them a choice. These are the things we got to get done. Tell me the order you want to do it in. All right, our goal is to make sure that they are physically and mentally prepared and have some support and discharge planning. All right, so I'm going to go through, this is more like our interventions of what we're going to be doing for a pre-op situation. And I've said over and over and over again, focus on education. I think y'all are getting those. The instructions and why they're doing what they're doing. Another very, very important thing, and most everybody that's been in the hospital, you've signed an informed consent. Do you know what I mean when I'm talking about a consent form? The consent form is being signed by the patient saying that they're given their permission for this facility to do surgery on them or do whatever procedure that they need. The one thing that you got to remember is that it can't be because you're going to be responsible as a nurse to get the consent form signed. You are, and everybody struggles with this, use terminology that they understand. Like, do not put total abdominal hysterectomy with a bilateral saphenous oophorectomy. Because they know what in the heck. Y'all don't, half of you don't even know what I just said. Okay? So, it was a total hysterectomy with bilateral tubes and ovaries removed. So you gotta put that in a term that they understand. Like, I'm having my wound taken out. Or something to that effect into what I'm having done. And they're signing that they're giving your permission, or they're giving you permission to do this, okay? Now, the responsibilities of you as a nurse with the informed consent. It is not our responsibility as nurses to educate the patient on the surgery that they're having. Not what's going to happen. We're responsible for that, like interventions and all that kind of stuff. But as far as the surgery, the doctor is the one that tells the patient everything about the surgery. This is what I'm going to do. I'm going to take your uterus out. I'm going to take your ovaries out. I'm going to take your tubes out. Everything about that patient. Every detailed bit of information has to come from the physician. So when you're having them sign this consent form, you are not signing it saying that you gave the information. What you are witnessing the signature that the patient is saying, I understand everything that's going to be done through the education of the physician, and you witness their signature to that. Does that make sense? So you are not responsible for educating that patient on everything that has to be done in the surgery. What our responsibility is for the consent form is you're signing that you witness them signing it. That is all the consent form. That doesn't mean that we don't clarify if they need questions. But we have to make the decision that when we have them sign, when you are talking to them about signing their consent form, and they say, well, you know, I can't remember which side he was going to put me on when he went me in surgery. Is that something you can answer? Yeah. We're going to lay you on your left side. But if they say something like, you know, I can't remember if he told me I'd be cured after this surgery, or, well, I still have cancer. Is that something you can answer? No. So you got to make the judgment call. Does this patient, or do you feel this patient has been educated enough to sign this consent form that they know everything that's going on in the surgery and that you witness it?
For minors, it's the parents that are signing, correct?
Yes.
So they don't necessarily.
No. So my babies, just parents sign. So I don't want you to get caught up on, oh my gosh, I don't feel like my patient knew enough about it for me to sign. Then if you don't feel that they understand everything that you can't answer, you call the surgeon at that point. And you say, my patient doesn't understand this about the surgery. So you are just witnessing their signature. Does that make sense? Okay, but you gotta know what is important about that surgery that you don't feel that they understand. So that's all you're doing. I did put up here about Jehovah Witness too. Will not accept any blood products. No blood products whatsoever. Even if we try to talk to them, they're not going to do it. Now, I had a patient that was with my students a couple years ago on the oncology unit. Jehovah Witness, she needed, I think her hemoglobin was like maybe 5. And so I talked to her about diet. Well, she had cancer. She didn't want to eat. You know, so I tried to supplement her with stuff. So I got to talking to her. I said, you know, iron. That would be really good. Do you know iron comes IV? It does. Comes IV. So I got to talking to her about IV iron and seeing if that would be something that, you know, I don't want to, you know, force my beliefs on you in any way, but let's research this. So me and her got the computer out and we looked and see if iron was something that she could do, and she could. So we called the doctor and said, hey, she can do iron. And you know, within a couple days, she was getting more strength. She felt like doing something. So you gotta look, we have to respect that they're not gonna take blood products. They're not.
That is their belief. You cannot make anybody do anything. But we can look at other alternatives. So, I mean, my first thing was, oh my gosh, I got to get some iron in her. I got to get some, this in her. I got to make her. And she was like, I ain't hungry. And I was like, I know. I had to figure out some way to get her to feel better. So there's other alternatives that we can look at. All right. When you have someone that cannot sign their name on the consent form, then you can put an X. The patient can put an X, i.e., they cannot write. They are able to put, as we talk to them and everything, and we're having them sign it, they can put an X, but 2 RNs have to sign with them. Okay? So that's 2 people saying that I saw this patient sign this X. Okay? In a life-threatening situation that, let's say a patient comes in a motor vehicle accident and they're bleeding to death and I can't get a hold of their parents or whoever, their wives or husband or whatever, and it's an emergency situation and if we don't do something, the patient's going to die. What happens then is 2 doctors that are not associated, not the surgeon that's getting ready to do surgery, but 2 other doctors look at the situation and decide, is this a life-threatening situation? And if we don't do surgery, then this patient's going to die. Then the consent form can be waived. Okay? But never is a consent form waived unless we're in this situation. And we've got, and it's not really waived, it's that both surgeons are going to be signing that, saying that they have assessed the situation and realize that if we don't do something, this patient's going to die. Because I can't let people not go to surgery that are dying because I can't get their significant other on the phone. Okay? The other thing is that we have a lot of different cultures in our society now, and I cannot speak one bit of Spanish or any other language. So when I have someone that can't speak English, I don't try to even go into detail. I get a translator. I get a translator because they can't understand what I'm saying. When I worked as a labor and delivery nurse, I could say I knew push. It was about the only thing I knew in Spanish. So I'm not going to take any chance of not getting that patient to understand. I can go, all I have to do is call and say, I need somebody who speaks Spanish. Come down here now. I need somebody in here. And as I tell the patient, the translator can tell, or I tell the translator can tell the patient so they understand everything that they need to know. It's the same situation. We do the best we can to make sure somebody's educated. All right. I'm trying to see if I need to go on, or is this a good place to stop since I ain't got much for the rest of it?
We have 19 slides left.
You want me to try?
10 minutes.
Is it that y'all are tired or y'all are tired of hearing my voice?
Tired.
Coughing and all that kind of stuff. All right, any questions so far? It's pretty, it's interesting, but it's pretty straightforward, isn't it? And probably if you read the rest of my slides, you probably would say, okay, I've heard that before, or, so, yes.
If the patient doesn't have a power of attorney, then would it fall under implied consent if it was life-threatening situation?
You would go through the same way about getting 2 doctors to look at it and that kind of stuff. So, yeah. But if their power, what's happening a lot of times is people are putting their power of attorney and their PNR status and all that stuff at the hospital, and they are able to pull that.